Thank you, Brian, for that introduction, and thanks everyone for joining me for the last session of today. Like he said, I will be talking about ambulatory antibiotic stewardship, and primarily really want to focus on the targets, tools, and metrics that we have in this setting. I've got nothing to disclose, and I won't be talking about medications off-label. So when I was asked to give this talk, I really wanted to make it practical for those of you who might be thinking about starting or planning to expand an ambulatory antibiotic stewardship program. When I was developing our ambulatory antibiotic stewardship plan or program, I found there were a lot of different questions and opportunities that really needed to be addressed. And I was starting just kind of from the ground with very little experience, and so kind of had to figure it out as I went along. So today I'll be talking about some of those practical things for getting started, including why it's important, some high-yield targets, our key interventions, and some metrics to kind of figure out how you're doing along the way. So why it's important. Antimicrobial resistance is a growing problem in the United States with 2.8 million resistant infections resulting in 35,000 deaths per year. And some of our metrics have been worsening with a 50% increase in ESBL producing Enterobacteriaceae between the first antimicrobial resistance report in 2014 and the most recent report in 2019. Fortunately, some of our metrics have improved, which makes us hopeful that our antimicrobial stewardship efforts are actually having an effect, and so we hope to continue with that. But the key driver of antibiotic resistance is antimicrobial use, and so judicious antibiotic prescribing is essential to control this growing problem. Ambulatory antibiotic prescribing accounts for the majority of antibiotic prescriptions, anywhere from 60 to 90%, depending on which study you're looking at. In 2022, U.S. healthcare workers prescribed 236.4 million antibiotics in the ambulatory care setting, which is equivalent to 709 antibiotic prescriptions per 1,000 persons. Nebraska consistently prescribes more antibiotics than the national average, and we're frequently amongst the top 10 highest prescribing states. In 2022, we prescribed 824 antibiotics per 1,000 persons, so almost our entire state could have received an antibiotic. The CDC has really recognized that we prescribe more in the ambulatory care setting when historically we've looked at antimicrobial stewardship in the inpatient setting. So they did develop some core elements for us in the outpatient setting as well, in addition to those that are already in place in the inpatient care setting. We actually only have 4, but they're pretty much the same 7 core elements but squished together. So commitment, action for policy and practice, tracking and reporting, and education and expertise. And these really drive a successful outpatient antibiotic stewardship program. When you're thinking about starting this kind of program, you have to think about what infectious syndromes you're going to target, where are you going to apply those interventions to, what settings, and do you want to actually target all of the clinicians in those settings or just a subset? And there's really no wrong answer to these, but it really depends on the kind of resources that you have available. When I'm thinking about what infectious syndromes I want to target, what would be the highest yield? And so when we think about antibiotic prescribing by indication, about 50% of antibiotics that are prescribed for upper respiratory infections are suboptimal, while 60% for UTI and 88% for skin and soft tissue infections. And these are the most commonly encountered infectious syndromes in the outpatient setting. Upper respiratory infections account for 40% of all ambulatory visits that result in an antibiotic prescription, while UTI is 24% and skin and soft tissue is 18%. So when you're starting, these are the conditions that I would prioritize before I moved on to any other infectious syndromes, because they're going to be your highest yield. So when we're thinking about where do we want to apply our settings to, the majority of the data that we have in this setting actually comes from primary care clinics, and that's because that's where we're prescribing most of our antibiotics. In 2022, 30% of all ambulatory antibiotic prescriptions were prescribed by primary care physicians. And that really doesn't take into account the full volume of antibiotics in this setting because they completely excluded advanced practitioners from that metric, and they had their own kind of category, and they weren't separated out by specialty. So I would most certainly start with our primary and our immediate care clinics, with being our highest volume of antibiotic prescribing. But if you're planning to expand beyond that, you can look at specialty care clinics, the emergency department, and ambulatory surgical centers. The top 10% of prescribers actually prescribe 41% of all ambulatory antibiotics. So if you have limited resources, this is the subset of physicians that I would target, because you're going to get your highest yield for the least amount of effort. So when we're talking about our tools that we have in the ambulatory setting, they're a little bit different than what we have on the inpatient setting. And that's primarily driven by the fact that our patients are getting the entire duration of antibiotics at the time of the visit. And so there's no ability for us to intervene after that prescription is written. So the goal of ambulatory stewardship is really to prevent incorrect prescriptions and to make sure that we're using the right agent dose and duration from that time zero. I like to break these down into education and training, behavioral interventions, and clinical decision support. So provider education can take many different forms. It can be formal didactic education, it can be continuing medical education, or more informal things like e-modules or brief updates. Education is an important part of all ambulatory antibiotic stewardship programs, but it may not be effective on its own. Studies have shown that when you have education, it can significantly improve your antibiotic prescribing, but that change is actually reversible, and so it is not a long-lasting intervention. When you add on our behavioral interventions to these educational practices, education can have a significant impact and be long-lasting as well. One study showed that if they did a module, their guideline concordant prescribing for urinary tract infection improved by 22%, but with every additional 2-week period from that point, it decreased by 0.5%. When they then added a peer comparison on, it stabilized. We should not only be teaching our providers about antibiotic usage. Equally, if not more important, is teaching our providers in the outpatient setting about how to effectively communicate with patients about antibiotic usage and treatment plans. Communication skill training is a really effective and long-lasting intervention. One of the early studies showed that when primary care physicians receive communication skills training, they actually retain that skill and knowledge over years. Additionally, they found that it did not lengthen provider visits, which is one of the things that we hear as a concern. That same group actually did a follow-up study and found that primary care physicians that underwent communication skills training were less likely to prescribe antibiotics for acute respiratory infections than their colleagues who had not, and that change persisted for the 3.5 years that they were following these patients. There's a really interesting link between a provider's perception of patient expectations for antibiotics and antibiotic prescribing. If a provider thinks that a patient expects an antibiotic, they're actually 12 times more likely to provide one. And this behavior is really driven by the fact that providers are very concerned about patient satisfaction, and so they are concerned that if they don't give an antibiotic, they will get negative feedback. And so one way that I really like to kind of partner with my providers is by teaching them this communication skill strategy. And so it's a 5-step process. It involves giving the patient a clear diagnosis, both negative and positive treatment recommendations, expectation setting, and then contingency plan. And I really chose this approach to use because these components have a lot of data behind them regarding patient satisfaction. One study looked at the effect of positive and negative treatment recommendations on visit satisfaction, and they found that if you receive both positive and negative recommendations, the patients scored 16% higher on satisfaction. And so a positive treatment recommendation is basically telling your patient what is going to work, like symptomatically, so using a decongestant in an acute respiratory infection, whereas our negative treatment recommendations are, why is an antibiotic not going to work here? And this study found that there was no association between positive recommendations only or negative recommendations only with visit satisfaction. And additionally, there was no association between an antibiotic prescription and visit satisfaction. So really, it was the communication strategies that improved satisfaction. The contingency plan is another really important step, and this is basically talking with your patient about how they will follow up if things don't get better. And so another study looked at a pediatric patient population diagnosed with an acute respiratory infection, and they looked at the association of a contingency plan with the patient satisfaction. And they stratified their findings by whether or not the patient's family expected an antibiotic at the time of the visit. And so if they expected an antibiotic but did not receive one and had no further education, they had the lowest satisfaction scores. If they expected an antibiotic and did not receive one but got a contingency plan, they actually had the highest rate of satisfaction. And that was even higher than the patients that expected and received an antibiotic. And so really that highlights the fact that it's really the communication and the education that these patients are looking for, and that is what raises that patient satisfaction score. And behavioral interventions are the main kind of the bread and butter of outpatient antibiotic stewardship. And again, that's because most of the time, the reason that providers are giving an antibiotic when it's not indicated is really not a lack of knowledge, but it's just concern over the patient satisfaction and diagnostic uncertainty. One of the most common behavioral interventions that we use is an antibiotic commitment poster. And so antibiotic commitment posters have been shown to decrease antibiotic prescribing for upper respiratory infection by about 20%. And so these are typically signed by all the clinic staff, and then they're publicly displayed in the examination rooms and waiting areas. And that really helps the provider to communicate with patients that this is a priority of our clinic and not just of me, myself. And so that can help really steer the providing or the prescribing. And it also really leverages social accountability, which can improve prescribing as well. So you can make your own commitment poster like we did, but there's also a lot of free templates available from the CDC and AHRQ that you can get and download and use for free. So the other really important behavioral intervention that we often use is peer comparison. Peer comparison is essentially you pick a certain metric that you want to follow and you send feedback to your providers and compare their performance with that of their peers. And so this really leverages social and consensus norms and improves prescribing. One study showed that in an acute respiratory infection, with peer comparison, there was a decrease of 16.2%, and that was statistically lower than what we saw in the control group, although the control group also did have an improvement over the intervention period because often if we're watching them prescribe, they prescribe better. This is what our peer comparison report looks like. We give them the overall appropriate antibiotic measure at the top. We compare that to their peers, and then we give them kind of the components that go into the overall appropriate score. In addition, we give them both positive and recommendations for improvement. That kind of helps them know what they're doing well and where they could improve upon. And we've found that these reports are better received and have more of an impact when it comes from a source of authority, when the feedback is direct, and when it's designed to be emotion-laden. Like I said, the other reason, other than patient satisfaction, that we often see providers giving antibiotics when they're not indicated is diagnostic uncertainty. And so one way to combat diagnostic uncertainty prescribing is by using delayed prescriptions. And so there are multiple ways that you could do this. You can either have patients recontact the clinic for a prescription, you can post-date a prescription so they fill it later, they can actually come back to clinic and pick up a prescription there, or you can give them a prescription at the time of visit and say, please wait to fill this unless you're not feeling better in 5 days or things get worse. And one study found that if you did delayed prescribing, the patient picked up the prescription anywhere from 33 to 39% of the time, and that depended on which strategy was used. But if you didn't give them a delayed prescription and you didn't prescribe at the time of the visit, they still ended up getting an antibiotic 26% of the time, so really not a significant difference. So this can help combat diagnostic uncertainty. It should never be used if the condition that you're prescribing for shouldn't ever get an antibiotic or should always get an antibiotic. It should really just be this middle ground of, maybe this does need an antibiotic if things don't get better. Institutional guidelines can be a really helpful clinical support tool. We typically use these to direct providers to a specific antibiotic we want them to use for a given condition. And you can base it off guidelines, your local antibiogram, and then also some institutional priorities like decreasing a high-risk C. diff agent. But you don't have to reinvent the wheel if you're a small clinic or organization. Many institutions will actually make their guidelines available publicly, including the University of Nebraska Medical Center. And the CDC and AHRQ also have resources available. Using the EMR to improve antibiotic stewardship, the tenets of that are make the right thing easy and the wrong thing hard. And there's a ton of ways that you can do this, and you can be very creative. Some of the things I found most useful include requiring an indication for an antibiotic when they're prescribing, and that's really for two reasons. One is it really helps you track what people are using antibiotics for, or at least what they say they are. And also it makes the physician think for a minute of, well, what am I prescribing this for? And that can actually be enough to change the action. If you have the resources available, order sets can be really great for adding a chosen agent, a chosen dose, and a chosen duration if you can do those problem-based order sets. Justification alerts are very effective, but I will say that they contribute a lot to provider alert fatigue, and so I would use those sparingly and only if you've noticed a major problem with prescribing. And then finally, just defaulting our EMR settings, so making it the shortest duration, making it the correct dose, so physicians aren't trying to change those, because usually less clicks equals they're more likely to do it. I'm going to finish up talking about some of the antibiotic prescribing rates that we use, and then finish with the infection-specific metrics. So antibiotic prescribing rate is one of the main metrics that we use in the ambulatory setting. And so this looks at the number of antibiotics started over a given population. There's two ways to use this. One is at a population level, like I would use at the state level. And if I'm gonna do that, I use a denominator of patient population or patient years. But if I'm gonna use it at an individual clinic level, then it looks at the denominator being patient visits. So this is a really easy metric to get, but the one thing to know is it does not directly correlate to appropriate antibiotic use. They are linked in that if you have a higher antibiotic prescribing rate, you have a probably more inappropriate antibiotic use, but there's no direct link between those. The other one that I really like to use is the appropriate antibiotic rate. And so this one is a little bit harder to obtain because you need to have more variables from the EMR, and there can often be some adjudication of, is this working? And so it looks at the choice of agent, the dose, and the duration, and so it does give us a lot of information about why our prescribers are not meeting our benchmarks. And so it can be very helpful, but it can also be very difficult if you don't have a lot of resources. Some of our infection-specific metrics include the ARI HEDIS measure, which looks at the percentage of visits that don't result in an antibiotic, and it looks at all patients that are over the age of 3 months diagnosed with an upper respiratory infection. So this one's pretty commonly used because it is a validated metric that's out there, and some institutions will actually use this as pay for performance, but that's certainly not universal. And then sometimes there is not a metric for you to use, and you have to kind of come up with your own. So with skin and soft tissue infection and urinary tract infection, that appropriate prescribing rate is not very useful because they should get antibiotics for those conditions, but maybe they're not using the right one. So this is where I actually pull out the appropriate antibiotic rate. And so on the screen, you'll see what we are currently using for urinary tract infection, and something I'm actually currently working on validating. And if you're just not sure where to start, or you have a program and want to know how to improve it, ACAP now has an outpatient antibiotic assessment This is an assessment that's really just for us to help you. It's non-regulatory, there's no cost. And with interested clinics and organizations, we're planning to start meeting over the summer to help give resources and suggestions for improvement for programs. So if you guys have any desire to be for some statewide help, we're happy to help you guys. And so here is the link to get to our survey that comes to us. And with that, I would be happy to answer any questions.